Hi everybody. Um, I'm Aphrodite Rose Starfire, and I just wanted to do a little correction on the information that I just posted. First, I want to preface that I am a medical professional. I am licensed to practice medicine and nationally certified to practice medicine. I'm a physician assistant, or a PA. That's like a nurse practitioner. Basically, in America, I function the same way as a doctor does. I can prescribe medication, I can do surgery, I can do everything a doctor can do. With that said, I don't really believe what's going on right now. But I was researching some information about the actual infection, and that it enters the cell via the angiotensin converting enzyme, and a lot of people take medications called ACE inhibitors, which are angiotensin converting enzyme inhibitors, or ARBs, which are angiotensin receptor blockers, which is a little bit different. So there was a big recall on ARBs recently, but I was looking about the connection between ACE inhibitors and ARBs with CV. And I don't really trust the information that you can find on the internet right now, but basically it says there's wishy-washy information, there's conflicting information, and there is the first kind of articles are geared towards not giving ACE inhibitors and ARBs because they say that people who are already on these medications, like for high blood pressure or diabetes, when you're on a long-term receptor blocker, your cells tend to upregulate and make more receptors to try to compensate. So you're blocking all the receptors, so the cell's like, I need to make more receptors. So they make more receptors. So they're saying that somebody on an ACE inhibitor already for a long time already has more receptors, thus has more of a chance for the virus to enter the cell. I don't really believe that. But in case you are a patient with this diagnosis, or you are a medical professional treating patients with this diagnosis, especially in the ICU, I say give an ACE inhibitor like lisinopril, or start the patient on losartan or valsartan. Because especially if they're novel and they've never had the medication before, if they have the infection and you give them this inhibitor, the virus won't be able to enter and infect new cells within the person. And thus the person should be less infectious to other people. Also, if they are in the ICU and on a vent, why not give it? Especially if they've never had it before, there's not enough time for the cell to upregulate new receptors, so you don't even need to worry about that. You want to reduce the viral load. And actually, there was more evidence to suggest that maybe even patients that do have an upregulation of the angiotensin converting enzyme receptor, it might be beneficial even to be on an ACE inhibitor to treat this infection. So it's the wild, wild west right now in medicine, and I say if you actually have this disease, you should start this medicine because it's going to stop the virus from entering new cells. So yeah, it seems like you probably would want to go with lisinopril over an ARB, but both medicines have been looked into. And I guess there is an actual medicine that is ACE2 inhibitor, which is the specific enzyme that this infection uses to enter the cell. But it's patented, but it hasn't been released yet. So, again, I don't really believe what's going on. I don't believe the numbers. In America, I've never seen anybody in one of those bubble things. So yeah, if you have this diagnosis, ask to be put on this medicine. It's going to work better than chloroquine or hydroxychloroquine, which are malaria medicines. I mean, might as well block the way the virus gets into the cell. All right. Love you all. Bye.